Okay, welcome to the second talk in the Foregut Pathology series. If you're with us last month, we had discussed screening and considerations for how we surveil Barrett's esophagus. This week, we're going to move into interventions. Get some slides to advance here. So looking ahead to next month, just a quick reminder to save the day, Dr. DeDelva is going to be talking to us about esophagectomy, the when, where, and how, which will be a nice dovetail to the end of this month's talk, where we're going to basically discuss everything up to, but not quite including esophagectomy for therapy of high-grade dysplasia and early adenocarcinoma. So we caught it early. Now what do we do? All right, again, kind of following up on last month's talk of how we can do our best work to catch these early, to do good detection work, good surveillance, and then now move into interventions. And I don't have any disclosures. We've kind of gone over the objectives a little bit already. I'm going to look at options for those early stage adenocarcinomas as well as high-grade dysplasia, and then look at some of the recent advances in surgical endoscopy. So a little bit of a review of a couple key points from last month so that we know what we're talking about. We have the same language. So Barrett's esophagus, we want to define that, though there are many definitions. Most practically or most commonly, we're going to call that the replacement of the normal squamous epithelium of the distal esophagus with a metaplastic intestinal type columnar epithelium. And this is our progression that we're going to commonly see, and we're going to focus mostly now on what happens at that dotted black line and beyond as we get to high-grade dysplasia and invasive carcinoma, moving out of those typical glands and goblet cells. So this would be a standard H&E stain. We see the goblet cells highlighted here. And then as we move into more dysplasia, you see some of the nuclear atypia and crowding happening in these images here. So last month we discussed the sort of unknown risk of cancer when it comes to Barrett's esophagus without dysplasia. But as we talk now this time about dysplastic Barrett's esophagus, that is much more clear that there is a risk, probably 6% per year as a reasonable number to think about at a minimum. As we look at the AIM trial that we're going to talk extensively about, there was a RFA randomized trial. They had 19% of their patients that progressed on to cancer under surveillance from high-grade dysplasia. So it certainly can be higher. So the question now, as we look at dysplastic Barrett's esophagus, whether or not we should just be watching these, surveilling them, or doing something therapeutic to treat them. And most of the professional societies are going to come down with an opinion on that. And generally, it's going to be towards intervention. So looking through those society guidelines, they reference preferentially 2 randomized controlled trials to address that question. And in the instance of low-grade dysplasia, there was an 80% risk reduction with ablation. You still see you see up to a quarter of them progressing on to adenocarcinoma under surveillance. And with high-grade dysplasia, even more so to that point, a third progressing under surveillance with a significant risk reduction in the ablation arm. So just based simply on that, whether or not we should surveil these, we come definitely against that. However, whether or not we should operate on them is an interesting question. Do they deserve esophagectomy then in that case? So this is an interesting little topic to do a quick dive into. So this is the classic paper that a lot of us are taught in surgical training from J.D. Richardson in University of Louisville. So they had 11 of their own patients, and they looked at all the published incidents of this to that point, and combined for just under 100 patients who had esophagectomies for Barrett's with high-grade dysplasia. And they found 41% of those had invasive cancer. So that's the number that a lot of us learn, is that you need to take out any esophagus that has Barrett's with dysplasia, because 40% of them are going to have undetected cancer. So that's been certainly studied further since that time in the mid-90s. So this is a meta-analysis from 2008 that reviewed 30 studies and pulled out 200 plus patients who had esophagectomies for Barrett's with high-grade dysplasia. And in those, you find that only 12% had invasive T1B cancer or greater. So considering that high-grade dysplasia and T1A cancers would be amenable to endoscopic therapy nowadays, we'd see then that only 12% of those went on to have cancer that probably needed surgical intervention. And cancer was found in 11% that had a visible lesion, 3% if there was no visible lesion. So again, the more and more to the idea that you don't necessarily need to de facto take these out as soon as you have a biopsy that says high-grade dysplasia if there's no visible lesion. University of Pittsburgh had a single institution series of 68 esophagectomies with basically the same outcomes. 11% had a T1B or greater lesion. And again, if there was no visible lesion, there was only cancer found in 5.9% of those. So very comparable to the meta-analysis at large. Then the SEER database was queried, and this is a 2014 publication looking at esophagectomies for T0 or T1 adenocarcinoma over a 10-year period. And you've got the majority of those getting esophagectomies and 20% getting endoscopic therapy. And we see that the cancer-related mortality is no different between endoscopic therapy and esophagectomy at 2 years and at 5 years. But interestingly, the endoscopic therapy patients had a higher mortality attributed to non-cancer reasons, going to the idea that those are patients who were probably higher risk, and that's why they didn't have esophagectomy in the first place, but nonetheless wound up with a similar cancer-related mortality. So then to kind of round that out in terms of the gastroenterology societies, this is from the ASGE, and Barrett's with high-grade or intermucosal cancer, they recommend against surgery. Looking here at the NCCN guidelines, which we would think of, largely as surgical guidelines, we see some similar trend in the in situ cancer and the T1A. They have endoscopic therapies as the preferred method. And then even in superficial T1B, endoscopic resection followed by ablation as an option, though not listed as preferred at this point. And then finally, this whole T1B category has some options within it and bears a little bit of deeper investigation, but we're not going to get into that just yet. We're going to come back to that in a little bit. So now looking at the Barrett's with low grade and high grade, whether or not we recommend endoscopic eradication therapy compared with surveillance, we're going to look more at those therapies as delineated by the society guidelines. So contemporary therapies is how they're categorized in the guidelines. Recommendations for ablation are parenthetically coupled with RFA and cryo. And so we'll talk a little bit about each of those and compare the two and see where they're most well utilized. So this is some images from RFA, radiofrequency ablation of Barrett's esophagus. This is a primary circumferential ablation performed using a balloon-based bipolar electrode. You see in the top left, you see the balloon being deployed, and then the subsequent ablated area. Similarly, in the bottom right of the second set of images, you see the nice circumferential symmetric ablation that you get with the RFA balloon. So this is the gold standard in terms of ablative data. This is the New England Journal trial from 2009, the AIM dysplasia trial. It's a multi-center randomized controlled trial, 127 patients, where they ablated high-grade dysplasia with either sham therapy or RFA. And so we'll see here 90% complete eradication of dysplasia, 81% in the high-grade dysplasia. So there was a mix of low and high-grade dysplasia in the groups. And 22% in the controls had a complete eradication of dysplasia. Complete eradication of intestinal metaplasia, so all the Barrett's is gone, and 77% versus 2% of controls. And these two numbers lend to an interesting point that came up in a discussion previously, and that's that you see 22% of the dysplasias were eradicated in the control group that had a sham procedure. So that goes a little bit towards the notion that some of these will spontaneously regress on their own with better acid suppression. However, you see that only 2% of the Barrett's went away. So it's not as likely that Barrett's is going to regress, but that the dysplasia within it might. So that was a 1-year follow-up, the original AIM study. And then whether or not its durability is in question, they had 2- and 3-year follow-up of those study patients. So on the right, you see the chart from the original 1-year follow-up with the high rates of eradication compared to the control groups at 2 years that basically held 95% and 93% in terms of the dysplasia and intestinal metaplasia being eradicated. And a 3-year follow-up, they lose some to follow-up, but they maintain of those that were still within the study, very high rates of dysplasia without additional intervention, of eradication of dysplasia without intentional intervention. And here's the Kaplan-Meier analysis from that study showing greater than 85% of patients with eradication of dysplasia without maintenance RFA. And you see those are pretty flat curves going out over years. So then what do we know about spray cryotherapy? So this is a liquid nitrogen sprayed through a low pressure system at an extreme cold, minus 196 degrees Celsius. So we've got some single center studies and some registry studies, no level 1 randomized data in terms of efficacy, but they have this single center from 2013 with 32 patients who had high-grade dysplasia, had a 100% eradication following a standard treatment protocol similar to RFA of every 2 to 3 months for a year. They had 84% elimination of intestinal metaplasia, and that's at the 2-year follow-up. And at the last follow-up of any of those patients, which range from 24 to 57 months, they had still maintained a 97% elimination of high-grade dysplasia. This is a 2017 review of 50 patients with high-grade dysplasia. And again, you see similar good 3-year durability in the elimination of both high-grade, low-grade, and intestinal metaplasia. And at 5-year data, they still have 90% elimination of high-grade dysplasia. The incidence rate, and this is another good way to think about this data in terms of how we apply it clinically in our practices, the rate of recurrent intestinal metaplasia was 12% in these groups. So once they've been eliminated, what percentage of them are going to come back under surveillance? So just returning of Barrett's was 12%, return of any dysplasia 4%, and return of high-grade dysplasia or cancer in only 1% of patients. And that's useful in terms of how you think about it. This is just a graphical representation of their 3- and 5-year outcomes showing really good elimination of dysplasia and then sufficient elimination of intestinal metaplasia. So this is just a quick video of a patient that we've been treating with cryoablation. You see the white light and the narrowband images on the left of the area of dysplasia. And this is a patient that's already had some treatments. And so you notice the white light imaging has some heterogeneity to it. But in any event, we'll see here in the video, you've got the spray catheter out the tip of the scope, and then you have a decompression tubing there that's placed prior to you beginning spraying. And you're just gonna work your way around systematically, freezing a segment at a time. And here you see the good freeze being deployed, and then as is not uncommon, the screen beginning to kind of freeze up at the very tail end as you finish your freeze. And then this is what we see afterwards. This is the effective good cryoablation. So some more paper. So there's a National Cryospray Registry, which is a voluntary registry. They have 96 subjects pulled in this publication with a mean follow-up of just under 2 years. Low-grade dysplasia eliminated in 91%, high-grade dysplasia eliminated completely in 80%, with about a 60% eradication of Barrett's. Meta-analysis of 386 patients over 9 studies has a similar type of outcomes, 86% elimination or eradication of high-grade dysplasia. And interestingly, this one points out the failed RFA patients, which is one of the areas where cryospray is utilized, is patients who have gone through an RFA ablation and have had persistence of disease or recurrence of disease. And in those patients, there's an 81% complete eradication of dysplasia, and even 58% of the Barrett's eradicated with cryospray after failure of RFA. So leaning briefly again into that idea of salvage use for the spray liquid nitrogen, this was a series of 19 patients who had failure of RFA to eradicate their high-grade dysplasia or intestinal metaplasia. And once treated with liquid nitrogen spray, you see a 88% improvement in pathology. So a step down from whatever they had. 75% had complete eradication of their dysplasia, and Barrett's was eliminated entirely in 30% of those patients. So these are not commonly seen head-to-head in any of these studies. We see a lot of one or the other, single series, single center series. So this is the rare head-to-head where an institution was using both technologies and compared their outcomes. 154 patients with dysplasia split evenly between the two modalities. RFA did have a higher odds by threefold of completely eliminating the Barrett's, but their eradication of dysplasia was similar between the two, not statistically significant difference, although slightly higher for RFA, trending in that direction. So that's the story on efficacy. So let's look at some of the other aspects of the two modalities that come up in conversation with patients and providers. So one is stricture. For RFA, there's a meta-analysis that had a pooled stricture rate of 5%. There's the AIM trial that we talked about earlier, where they had a 7.6% stricture rate. For cryospray, there's the voluntary cryospray registry, where there was only one stricture of 96 patients. And then in the single site study referred to earlier from 2013, they had 3 strictures that required dilation out of 32 patients for a rate of 9%. So both are low, but that's the data on them for right now. On pain, we have a randomized trial comparing the two. So this one's a little more definitive. So they had 94 patients at 4 institutions that they were looking at. The immediate post-op pain was significantly higher in the RFA patients, in particular the circumferential RFA patients at 65% compared to 17% for the liquid nitrogen. And then that maintained 2 days post-operatively, where both groups saw a slight increase, but still a substantially larger one in the RFA group. And importantly, I think, particularly in this day and age, the need for pain medication afterwards was 73% in the circumferential RFA and only 25% in the spray cryotherapy, which is potentially meaningful. And so ultimately, the odds ratio put the pain after RFA at about 5 times that of spray cryotherapy. So definitely a difference in that area. And probably some of that comes down to the depth of impact that the two different modalities utilize or take advantage of. So RFA depth with debridement is seen to be the mucosal level, not getting down into the submucosa, whereas spray liquid nitrogen has the ability, although it depends on how you utilize it, to be as deep as the muscularis propria. And that has a big impact when we think about pain in particular, as we have vagal afferents and spinal afferents in the mucosa, submucosa, and muscularis propria as indicated. And so when we look at the depth of RFA, it's going to have some impact at the superficial level, but is going to leave those deeper vagal afferents and spinal afferents intact, likely conveying some of that difference in pain that we saw. Whereas cryotherapy is more likely to penetrate deeply through those layers of afferents, creating a cryoanalgesia and likely kind of numbing to that pain medicine, or to that pain effect, so to speak. Another interesting topic is buried glands or subsquamous intestinal metaplasia, SSIM. This is something that I didn't know a lot about, but I'd heard it discussed. It's the presence of Barrett's metaplasia beneath an intact layer of squamous epithelium. And so most biopsies, the vast majority, are too superficial to detect these. So the fear, of course, is that we're ablating across the surface and we're leaving these buried glands that can take hold and grow into invasive cancers sort of under our nose without us knowing. Fortunately, those early fears have not been corroborated, and we haven't seen that as a growing trend. Cohort studies show that they have been, SSIM is present prior to ablation in a large percentage of these, and that it may actually decrease with ablation. Obviously, the lack of deep biopsies is going to make this challenging to sort out, but in the AIM trial, they had 25% of these noted prior to ablation and only 5% present afterwards, so they seem to have had some impact even on these buried glands. So as a final summary, just kind of going through the different comparators, and this is just something I made, putting the two together so I could try and get my head around it. As we look at their ability to eradicate high-grade dysplasia, they both land in pretty high numbers in the 80 to 90% range. We have to give RFA a nod for the randomized controlled trial and the consistency or the durability of that 90% eradication number being slightly higher. Similarly with intestinal metaplasia, I think that regardless of the quality of the data, it does seem that RFA has a slightly higher rate of elimination of intestinal metaplasia. We know that from a durability standpoint, they're both durable from the data that we have available, but there's slightly higher quality evidence for RFA. We do know that the depth of treatment is deeper with spray cryotherapy, and that along those lines that they do have less pain. In regards to stricture, it appears slightly less for cryotherapy, but there's definitely a lack of good data there. And for buried glands, there doesn't appear to be any difference. So in conclusion, I don't exactly know what's best there. I think they're both good technologies, and there's clearly a role for spray cryotherapy as a secondary intervention. Whether or not you want to use it as a primary intervention, I think that's reasonable, but still not quite as well supported in the literature. So moving past that into the sequel, or the next step of the phase here, is early stage adenocarcinoma as we move through a high-grade dysplasia. So when we're talking about cancer, particularly esophageal cancer, this cut line of the nodal disease is nearly universally the #1 predictor of survival and long-term quality of your treatment. So finding these patients prior to progression into nodal disease is critical, and knowing what treatment to give based on nodal disease as well. So that brings us back to this discussion of the T1B territory with these superficial tumors that are beginning to penetrate more deeply, and how that's impacting their risk of nodal disease. So I'm going to blitz through kind of a stack of different studies that assess this, but in essence, we're looking at, here we see the mucosal layers sort of grouped into the M1 through 3 category. For the purposes of this discussion, splitting those out isn't really necessary. And then in the submucosa, looking at 3 layers of depth of penetration, ostensibly this being kind of the top third, middle third, bottom third. There's not an absolute depth of penetration that matters, because each cut and each patient is going to have a slight variance in that number. So some of these will say 100, 150 microns, 200 microns, but in essence, you're going to take it in thirds. And so these are going to be a series of different studies who have had esophagectomies and then looked at these early stage cancers for nodal disease and how it correlates to depth of invasion. So anywhere from 1%, 7%, 8%, generally speaking, there's a bit of a dividing line at the submucosa, SM1, the superficial submucosa, having a low rate of nodal metastasis, not 0, but close to what we would think of as mucosal disease still. So something in the single digits. And then there's a big step off once you get to SM2 and 3, where you begin to see that 40, 50% risk of nodal disease, that if you were to address this only endoscopically, this would go unnoticed and or untreated. And that's an important distinction in how we approach these. So different ways of approaching endoscopic resection. So EMR, or endoscopic mucosal resection, most folks in the gastroenterology community are going to be familiar with, surgeons maybe less so. But in essence, we're going to do some kind of a lift, some kind of a band or snare to resect these. It's commonly going to lead to sort of a piecemeal removal, depending on how big a lesion you're talking about. And it's something that, I think of as an excellent biopsy, but not necessarily something that we would use for or consider a curative resection often. So what are the shortcomings, and why does that, and how does that impact what we do? So obviously, lesions that don't lift are not going to be good candidates for EMR. Larger lesions are going to be challenging to get on block, and so above 15 millimeters is commonly a cutoff for what we can do with EMR. And then certainly larger lesions that are removed piecemeal are going to have issues. Maybe most important is limiting the precise measurement of depth of invasion. So kind of building on that, the esophageal cancers taken in the SEER database, the tumor size in about half of them is over 1.5 centimeters, or over 15 millimeters, which we know is about the limit. This study from 2011 sort of categorized that, but we know that about 15 millimeters is around the limit, and that's the limit set in the guidelines, usually for using EMR. So that means that we've got more than half of these early stage mucosal or early submucosal esophageal lesions that are not going to be amenable to EMR resection. And then important to us as surgeons, this last piece, there's minimal or no submucosa present in 1/4 of EMR specimens. And back to that earlier slide, submucosal invasion and the depth of submucosal invasion is really key in figuring out how best to counsel patients. So that leads to the introduction of ESD, or endoscopic submucosal dissection, something that we've begun practicing here, that's going to give you an opportunity for an en-bloc resection of those larger lesions. So this is just a kind of a cartoon schematic, and we'll look at a video in a second, but in essence, we're going to be lifting, tunneling, and completely resecting a lesion. So this is, in an ideal circumstance, what you're going to get, a broader lesion that kind of spans an area. You could go through and piecemeal out all of this via EMR, But what this is going to allow you is for a better oncologic assessment of the entire area and the margins, and better able to make a treatment plan based on that. So why does R0 matter? This is a good comparator looking at a small group of ESDs and EMRs, and that equivocal path is key here. So in the ESD group, there's no equivocation. They know the depth on all of them. Whereas in the EMR, you're going to have a percentage of these, and here they've got 36% or a third of them with equivocal path that are going to go on, and you look at the next bottom half of that, and the final pathology of those that went on to esophagectomy wound up being mucosal lesions in 3 of those. So that's 3 people who didn't need that esophagectomy. Whereas in the ESD group, nobody went on to an esophagectomy they didn't need. And so that's a big deal when you're counseling patients, given the magnitude of that operation and the choice. So comparing ESD to EMR, however, there's, this is what you would expect to see, right? So really good numbers for ESD when it comes to en bloc resection, curative resection, local recurrence. It's going to be better. You would expect it to be better. The problem is that it's very technically difficult, takes a lot longer, carries a little higher risk. So that's the reason that it's not broadly deployed. And the Western guidelines represent that fairly well. If it's a gastric neoplasm, both the European and the American gastroenterology guidelines are going to, give ESD top billing or right alongside EMR. But when it comes to Barrett's, it hasn't been shown to be superior to EMR, and that's largely because the Western experience with it is minimal compared to the East, and so we don't have the good outcomes, the speed that are necessary to make it a preferred recommendation. So it gets kind of an equivocal recommendation in the AGA and ESGE. So here's a quick video, sort of cut down for time, because as alluded to, this can be a lot longer procedure. This is an endoscopic tumor that was biopsied, and EUS indicated that it might be submucosal only. So we are going to mark it out here with cautery, sort of setting our margins. And then the video is going to pick up a little ways in. So at this point, we've made the distal cut, which is the first step in the ESD. So we've gone to the gastric side here. So we've made a cut down to, you can see some muscular fibers there, the sling fibers on the gastric side. And now as we kind of back up to gain some perspective, you see the tumor sort of at the 2-3 o'clock area there, kind of rocking around the scope, right? It's got some definite bulk to it. And we're going to come back up to the proximal side now, to the oral side, and we're going to begin working at it via tunnel technique, similar to POEM, where we're going to, here we're using the hybrid knife to both inject saline to lift the tumor as we go, and then cautery to dissect and take down vessels. So we're going to speed this up a little bit to get through this lengthy procedure in a reasonable amount of time. And you'll see here as we engage with and identify some number of relatively large vessels that we're going to handle with cautery. We want to try and stay as close to the muscular layer as we can. Again, we're hoping to identify submucosal depth of invasion and to get clear margin on that. And so we try to work down on the muscle layer as we're now kind of traveling underneath the tumor. And then we need to complete that tunnel. So we want to see ourselves coming out the opposite end. This is one of the rare times in endoscopy where you suddenly see an opening of daylight on the other side and you feel good about it. So this is sort of an intentional perforation in a sense, where we're going to come out the other side of this tunnel underneath the tumor again. I'm going to kind of clean up some of the edges and like I said, this is a several hour case, sort of truncated down to a 4-minute video, but we're kind of trimming down at the edges here. You see the muscle beneath us and the tumor above us. And then we just have to take the sides down, which I say that's often one of the harder parts. This is the tail end of the right side. I thought I'd give the audience the satisfaction that took me hours to earn here. This is the last little bit, which is very gratifying. You get the tumor free, and you know that you're almost home free. And now we're going to do the left side. We've at this point placed a snare and clipped it to the right side in order to give ourselves some counter traction. And you see we're just finishing off that last little connection on the left, and now we've got the whole tumor here with the clip and the snare being delivered out of the esophagus. And then we're going to get just a quick last look at what's left behind, sort of that bare area of muscle. You're going to look for any perforations, any bleeding, but that's going to remain uncovered, and very low, rate of leak and perforation, but something that we have to be attentive to. So this is that patient's final pathology, and as you can see, there's tumor invading through that top line, the muscularis mucosa, the whole submucosa there. You see all of those crowded and atypical, kind of misarranged nucleoli, and all the way down to the very deepest part of the submucosa. So this was a tumor that was deeply invasive, and is going to require either an esophagectomy or definitive chemoradiotherapy, depending on the patient and the remainder of the assessment. So trying to understand when is it best to deploy this or other endoscopic therapies, how do we assess the risk, and how do we counsel the patient? So depth is what we've been talking about principally, and that is important. This is a scoring system that was developed just as a thought experiment. This isn't something that we necessarily use in each patient, but it gives you some sense of the value of different aspects of the evaluation. So in their scoring system, a higher point total is actually given to other things than depth. So lymphovascular invasion and the differentiation of the tumor weigh heavily in that point total. And so that really has helped inform me, rather than just focusing on the depth. If we've got a biopsy with poorly differentiated tumor and lymphovascular invasion, it's very unlikely that we're going to get away without nodal metastasis, and it's probably not a patient that's going to benefit from a mucosal resection. So this is a kind of a parting thought, a really interesting study that we'll introduce next month's talk with some food for thought. We know that T2 by ultrasound is a problematic staging area. Half are understaged, half are overstaged. It's difficult to get this one right. And so this study proposed, well, what if we endoscopically took a shot at all of those, and what would that wind up looking like? And so this is from MD Anderson, and basically they had a group, 75 ultrasound T2 and zeros, and they were treated different ways, and what were the outcomes? So these are small numbers, but this is meant to sort of give you an idea of what might be down each of these pathways if you wanted to treat patients like this. So in the case of the 30 that went to EMR, 17 of those were curative. They wound up having T1A or superficial T1B tumors that didn't require other treatment. 13% were not. They couldn't lift, they had to abort, they invaded the muscle, and those patients went on to further treatment. And then in the group that went to esophagectomy who did not have EMR, you found that 6 of the 10 who had upfront esophagectomy had mucosal disease and probably could have been treated endoscopically. And then in the big cluster of those that are treated with induction therapy followed by esophagectomy, you're going to have some downstaging, but you still have a large number of these that wind up with in situ or mucosal disease only, and you had all the attendant risk. Here they had a 3% 30-day mortality in that patient group. So it's something to consider, that even in these that look like a T2 by ultrasound with muscular invasion, that it might be worth endoscopically taking a swing at these first to try and spare some percentage of patients an unnecessary esophagectomy. So that is all we have for today. Thank you all.